Hi Pete, I was just wondering if you could tell me what the crack is with these new hypertension guidelines.
That is an excellent question, Jamie. Managing hypertension is one of the first prescribing skills we'll learn in general practice. But sadly, the evidence shows that we're actually getting less effective at managing this condition as a population. Between March 2020 and March 2021, the number of adults under 80 with hypertension who were treated to target fell from 67.5% to 46%. Whilst obviously the pandemic played a big role in this, we really need to modernise our approach to this condition if we want to hit NHS England's goal of 80% of patients being treated to target by 2029. Our hypertension protocols are clearly in need of a reboot, so this video is as much directed towards senior clinicians as ones just starting out their careers. The new prescribing guidance advises us to have a much lower threshold for adding second or third line agents and using a combination of all three drugs at low doses before titrating everything up. This can feel like the opposite of what we'd want to do from a polypharmacy point of view, and I see a lot of clinicians falling into their old habits of slowly titrating up a single agent to the max dose before adding a second one. But this is actually pretty ineffective for managing blood pressure, and only 25% of patients will achieve control with a single drug. There are biological reasons for this, and adding a low dose of a second medication is around 5 times more likely to get the BP in range than doubling the dose of that single drug. By using lower doses, we also minimise the risk of dose-dependent side effects and will reduce the number of wasted blood pressure and blood test appointments during the titration. What's more, when we look at the reasons why, you'll start to wonder why we ever managed blood pressure the old way. Let's take a look. So blood pressure is primarily determined by 3 factors: renal sodium excretion and its impact on plasma and total body volume, cardiac performance, and vascular tone. These factors underpin the hemodynamic determinants of BP, which are intravascular volume, cardiac output, and systemic vascular resistance. The behaviour of these processes is fine-tuned by the sympathetic nervous system and the renin-angiotensin system, in response to a range of genetic or environmental factors, along with any chemical substance the person might decide to expose themselves to. Whilst it is possible for a person's blood pressure to be raised by a single mechanism, in the vast majority of scenarios it's a complex mix of all the factors we've mentioned. What's more, even if we were successful in identifying the single process and targeted this with a specific drug, over time the body introduces countermeasures to reduce the effectiveness of that treatment. This was demonstrated in a meta-analysis of 354 trials, which showed a single agent only lowered the BP by about 9.1 over 5.5 more than placebo. As a comparison, a different meta-analysis showed that if someone takes up yoga and it includes postures, meditation and breathing exercises, after about 20 weeks they can expect to see a blood pressure of around 8.17 over 6.14 versus placebo. There's 7 different classes of antihypertensive drug on the market, and most of these classes have several drugs within them. So how do we decide which combinations to use? In current guidelines, the first 3 classes to consider will be either a drug which blocks the renin-angiotensin-aldosterone system, or RAS drug, a calcium channel blocker, or a thiazide diuretic. Your local formulary will have first-line options for each class, but for this video, I'll use the GMMMG first-line options. The mechanisms of these drugs can complement each other if we're clever about it, so let's learn which combinations work best. ACE inhibitors, or angiotensin blockers, are the first-line option for a lot of patients. There isn't really much between them evidence-wise, so for this we'll call them RAS drugs for short. Confusingly, the activity of RAS inhibitors is not limited to the RAS pathway, and these drugs exert effects on the sympathetic nervous system and other important pathways which influence blood pressure. These drugs reduce pressure within the kidney and have benefits in salt balance, so on paper you'd expect them to be powerful BP lowering drugs, but in practice we only see a big drop after the first dose. After this, the body counteracts them by simply producing more renin and angiotensin, tightening up the blood vessels again. This means the benefits in sodium excretion and cardiac performance are undone by an increase in vascular tone, leading to only modest improvements in BP. When we combine a RAS drug with a calcium channel blocker like amlodipine, this increase in vascular tone is undone by the CCB, leading to a much bigger drop in blood pressure. Also, the peripheral edema seen with the CCBs can be reduced by the RAS drug, as adding this reduces the pressure gradient across capillary membranes. Conversely, when CCBs are used on their own, the drop in vascular tone activates the sympathetic nervous system and the RAS pathway, undoing some of their effectiveness as a result. The addition of a low dose of RAS drug blocks this activity, leading to a bigger drop in blood pressure than the sum of each individual drug. Thiazide diuretics are useful options for patients with symptoms of fluid retention, especially if we have concerns about heart failure being present. But by reducing the intravascular volume, they activate the RAS system, leading to sodium and water retention and vasoconstriction. The presence of a RAS inhibitor, even at a low dose, will help to blunt this effect, and the potassium sparing effects will reduce the risk of hyperkalemia that we see with thiazide diuretics. Finally, what happens when we combine CCBs and thiazide diuretics without using a RAS drug? The answer is modestly increased blood pressure control. These drugs both offer pretty good BP lowering effects in their own right, so you might expect good results with them in combination. But actually, the two classes have an overlap in their effects within the body, so to get the best BP lowering effect, we would want patients to have a RAS blocking drug in place. So, using this knowledge, we can see how the recommendations in the Greater Manchester hypertension pathway fall into place. After we've confirmed they're definitely hypertensive using the guidance at the top, then addressed any medical or lifestyle causes of the high blood pressure, would go for the first line drug therapy, which is a RAS drug like lisinopril 10mg for patients with type 2 diabetes and patients under 55 years old, and a CCB like amlodipine 5mg for everybody else. Ethnicity is very important and should be confirmed before prescribing any treatments, as non-diabetic black patients of all ages should receive a CCB first line, and in terms of RAS drugs, I would recommend using an ARB first line like candesartan 8mg instead of an ACE inhibitor due to the risk of angioedema. This probably won't control the blood pressure on its own, so step 2 is to add the other first line drug, so everyone will be on a combination of amlodipine 5mg and a RAS drug. This will hopefully hit the targets, but if it doesn't, then step 3 would be to double the dose of whichever drug was added first. If this isn't enough, we'd then go for step 4, which is adding indapamide to this combination. If we're still having a hard time hitting the targets, then at step 5, we'd bump the second drug up to the max dose and recheck from there. After that, things can become very complex, so it's important we approach any new drugs very carefully, making sure any adherence problems have been adequately explored. If people are struggling to remember to take their tablets, try to work out a way of taking them all in a single dose, as this helps loads with adherence. Also, having an open discussion about side effects can help you pick alternatives which will fit them better. If we're confident they need further antihypertensive therapy, the drugs at the bottom of the guide are all valid fourth line options, but we need to carefully weigh up the next step particularly with spironolactone in patients with potassium levels at the upper end of normal. So we know that using a combination of treatments is the best way to reach blood pressure control. But let's circle back to the study I mentioned before, which looks at the effects of yoga, meditation and breathing exercises. This proved itself as a perfectly valid treatment option under the intense scrutiny of a meta-analysis. So couldn't we just combine yoga with a first-line drug and consider this the treatment combination? The answer is yes. Lifestyle interventions take a bit more time to kick in, but the brilliant thing about them is you can use as many as you like in parallel. So you could start your patients on yoga, salt restriction, a reduction in sugar, alcohol intervention, and a mix of aerobic and vigorous exercise all at the same time. Unlike drugs, each of these interventions has dozens of mechanisms of benefit for your patient, reaching far beyond the blood pressure itself. If your patient takes to these interventions well, but their blood pressure remains a bit high, don't be disheartened. This can probably be brought in range with a combination of low-dose antihypertensives. See you next time.